So not to keep everyone waiting, we're going to begin this evening's webinar. Good evening, everyone. Thank you for taking the time out from one of the sunniest days we've seen in the UK this year to attend this evening's webinar on avoiding heel pressure damage. Keep it simple, keep it safe. We're going to be exploring best practice this evening in pressure care and discussing the prevention of avoidable heel pressure ulcers. My name's Simon Dickinson and I'm the Medical Director of TaylorMade, and it's my honour to be chair for this evening. I'm an orthotist by profession and I'm TaylorMade's Medical Director, and I have seen firsthand the impact that pressure-related injury can have on patients and their families. We're incredibly proud at TaylorMade to be able to bring our three speakers together to present this clinical webinar to you this evening and to facilitate the discussion with these experts tonight. Heel pressure ulcer remains a significant challenge in healthcare, yet with the right knowledge, strategies and tools, we can make a real difference in patient outcomes and prevent avoidable harm. Our goal this evening is to provide clear, practical insights that you can apply in your clinical practice to enhance patient care, reduce anxiety and reduce costs for healthcare providers, whilst keeping solutions straightforward and, most importantly, effective. We have a phenomenal lineup of speakers, each bringing their own passion, expertise and experience to tonight's conversation. So firstly, we're going to hear from Jacqui Fletcher. Jacqui is a leading expert in pressure care. She's known for her contributions to preventing and managing pressure ulcers. She's played a key role in developing evidence-based guidelines, pressure relief devices and training programs to improve healthcare standards. Her work with NICE has influenced healthcare policy, advocating for systemic changes to prioritise pressure ulcer prevention. Recognised with an OBE for her phenomenal efforts, she will have a lasting global impact on patient care and clinical practice. Our second speaker this evening is a slight change to the programme. We have Lindsay Graham joining us today, presenting in the presence of Heather Hodgson, who unfortunately had to withdraw at the last moment. Lindsay is a tissue viability nurse working in acute services within Greater Glasgow and Clyde. She's passionate about her role and recognises the privilege of being part of a small dynamic team during her career. She has worked as a nurse since the mid-90s and has held various roles, including working in elderly care, haematology and acute medicine. She took on her current position 6 years ago, and she has also served as a senior charge nurse in the acute medical ward at the Vale of Leven Hospital. Our final and third speaker this evening is Mr. Duncan Stang. Duncan is an internationally renowned podiatrist specialising in diabetes foot care. He was appointed Scotland's diabetic foot coordinator in 2008 and led some absolutely unbelievable and key national initiatives, including the Diabetes Foot Screening Tool and the CPR for Feet programme. He founded the Scottish Diabetes Foot Action Group, which drives innovation in prevention and treatment. So what we're going to hear from these sessions, from these three speakers today, is their wisdom, their guidance to help us all to improve what we do clinically and ensure that we are adopting best practice. During the webinar, your mics will continue to be switched off and the chat function has been disabled within the chat. You do have, however, the opportunity to submit questions through the Q&A section here in Microsoft Teams, and we will deal with those questions at the end of the third speaker. So after Duncan's talk, I will come back on and field questions to the panel. So let's get started. I'd like to hand over to Jacqui Fletcher, OBE, to begin this session. Thanks, Jacqui.
Thank you, Simon, and good evening, everybody, and thank you for taking the time to join us this evening. We really do appreciate you giving up your evenings, and it's our pleasure to be able to talk to you about this really important topic. I'm sure it's no news to you all, this background or context that I'm going to share, but I think it's worthwhile reminding us before we start the session why we're so interested in pressure ulcers and pressure ulcer prevention. And despite the myriad of interventions that have been in place across the UK for 30, almost 40 years now, we know that pressure ulcers remain in the top 10 harms that we see. And we are made very aware of the fact that they cost organisations significant sums of money, and that may be in terms of their treatment or it may be about litigation. But I think far more importantly, we need to remember, in addition to those financial costs, pressure ulcers have significant impact on patients and their families and loved ones. And let's not forget that pressure ulcers also have a significant impact on our clinical staff. It's incredibly debilitating for staff when they go many, many days without patients developing pressure ulcers, and they're hugely dismayed if they get to more than a year and a patient in their care develops a pressure ulcer. They can be equally dismayed if they've not gone a week without a patient developing a pressure ulcer. We know that staff take it very personally, and they often feel that they're to blame for what happens, when often it's a system or process issue, or the patient is just very sick. And some of the guidance that we put in place and some of the regulations that we put in place result in our clinical staff becoming really anxious when patients are at risk or do develop pressure ulcers in their care. And I think it's important to remind us that we are actually counting pressure ulcers, and we're counting to see if we're making an improvement. And if we look back not too far ago to 2007, this was the first European survey that was done, and it surveyed just under 6,000 patients. And it's important because this was one of the first big surveys where we didn't rely on documentation. We actually checked people's skin. And we know that that does make a difference to the numbers that we find. What's recorded isn't always what's there. And you can see that the prevalence at that time of all pressure ulcers category 1 to 4 was around 18.1%. And what that meant that was 1 in 5 patients who came into hospital were developing pressure ulcers. At that time, the sacrum and the heels were the most common locations. And in that survey, they also looked at the care that patients were receiving and identified that only 9.7% of the patients that were in need of prevention really received the full kind of care that we hoped that they would receive. If we look at where we are now, we've got a little bit more data. So we've had 3 recent biggish surveys done, all following the same methodology as that original European Pressure Ulcer Advisory Panel one. And the most recent one, the one that was done in England, was over 10,000 patients. So this is a significant size audit. It was done across 23 hospitals. So there was a real mix of small hospitals, big hospitals, general hospitals, teaching hospitals, and a cancer hospital in there as well. And you can see that the prevalence here is 9.4%. That's half of where we were at before. So in terms of are we improving? Yes, we are. We have made a significant reduction across the last 15 years. But we also need to think about, is that good enough? Is it okay that now only 1 in 10 patients develops a pressure ulcer? Are there things that we can actually do better? And I do really think that there are things that we can do. And what are those things that we can do? We can think about how we work better together. You will all be very aware of the fact that if you have complex patients with complex diseases, they're multimorbid, on polypharmacy, then it's really important that we have teamwork involved. Not just teamwork within an organisation, but across organisations and systems, because we know there is significant variation in practice. We need to remember that prevention has to be our first strategy. It's far better to prevent a pressure ulcer than to have to treat one. And the way that we do that is focusing on bundling our care together. And we know from lots of literature, not just in the field of pressure ulcers, if you bundle resources, it's far more likely that staff will remember to do them. So whether in your organisation you use just the SSKIN bundle, or if you use the wider ASKIN bundle with the focus including now risk assessment, as well as that skin assessment, the services that the patients are involved in, and the keeping them moving, increased moisture, nutrition, and very importantly, giving of information to the patient and their family, and giving information to clinical colleagues. But we also need to understand the problem a little bit better. I think what we see is if you look back 5 or 10 years and you think about all the incident reporting systems you've been involved in, often the answer to why did this pressure ulcer occur is the same. So are we fully understanding what the challenges are? We know that still sacrum and heels are our most common pressure ulcers. And why is that? Is that because we're failing to focus on those or deliver appropriate care? I think for me, part of it is we have been a little bit misled by the education we've had. I think we have anatomical diagrams that don't always show us the best images. We have very static images. So when we're trying to explain things to people, it's very difficult. And whilst most people understand the concept of pressure, you can use the hosepipe analogy. If you squeeze a pipe, you stop the blood flow, you don't get oxygen and nutrition. We know more recently we focus very much on shear forces, But that's really difficult to explain to people. And I think even when we do all sorts of, telling them about people sitting up in bed or dragging their heels through sand, it doesn't really explain what happens to the tissues. And some of the explanations we have about stresses and shear forces from our biomechanical engineers can make it very complicated. So we've been very fortunate to have some examples from human dissection. So as you can see, this is a warning that the next two slides are anatomy slides. And I want to share with you an actual video showing you what's happening to the internal tissues. So as we go through, this is over the head of trochanter. And as I play the video, if I can just find a little button to click, you can see in the middle, that's the bone. And as you sit the patient up the bed, this is just the result of sitting the patient up the bed. Look at how the skin stays still, the fat all changes shape, and the muscle is moving, but the skin isn't really moving its position. And think about how all those cells in all those different tissues are subject to both pressure and to those shear forces, and how they are completely changing shape. Within that, what you saw over that hip area is there's significant depth to those tissues. But we're focusing on heels this evening, so I want to show you the anatomy of the heel. So what you can see here is, imagine that video playing out in this much more enclosed space of the heel. So if you can start to imagine those two videos coming together in your head and think about that, the thinness of that skin on the back of the heel with the very little subcutaneous fat, and imagine that movement you saw in the previous video and how that stretched and deformed the tissues, and how the pressure applied through that very thin skin with very little protective cushioning can very easily start to damage the heel. So it leads me to think about, if we have made a difference, but not enough difference, what can we do differently? Where should we focus? And we should focus on where we can make a difference. And if we know that sacrum and heels are our big challenges, then those could be the areas that we choose to focus our efforts on in order to maximise the benefits we give to our patients. But I think we overcomplicate things for our clinical staff sometimes, and also our patients, when we're trying to engage them in supported self-care or get them to be involved in their own care. So we need to really think about keeping our patients safe and how we do that in a straightforward way, but also how we keep our colleagues safe and keep everybody safe and free from harm. So there are some references there that I've referred to throughout the presentation, and I'm going to hand over now to Heather, who's going to tell you a little bit more about the work she's been doing.
Thank you very much, Jacqui, for that great introduction, and thank you for TaylorMade for inviting me to present. So keeping with the theme, I'm going to take you through a mnemonic of the words simple and safe, just as an easy way of remembering basic strategies to prevent heel damage. Skin checks. I cannot stress the importance of skin checks, especially under equipment. Anti-embolic stockings, foot protection, and fall socks. The most simple, basic, and core nursing skill is skin inspection, but this needs to be done thoroughly and not just a tick box exercise. All areas of the body at risk should be inspected properly, including the feet. And inspection means looking and feeling and touching for differences in reperfusion, for colour, especially in people with darker skin tones. You may need to look for nuances. Is it warmer? Is it colder? Is it softer? Is it firmer? Is there pain? We need to have an individualised care plan. One size does not fit all. I'm making a plea to you tonight. Please make it person-centred and not ritualistic. Please stop ritualistic care rounding, turning night into day, deliver care when it's required, involving people in the decision-making about their individual care plan. To do this, you need to listen to your patient and their families. What works for them? What will make it good for them? What will make concordance better for them? By having an individual care plan, this increases concordance, reduces stress and distress, especially when people are cognitively impaired, and reduces workload for nurses. Moisture management. Make it effective and consider all sources of moisture, including perspiration, incontinence if this is making feet moist, if there's urine running down the legs and into the feet, and maybe under foot protection. And some foot protection devices themselves can increase moisture. So again, these need to be taken off and the skin inspected. And I'm going to keep mentioning fall socks because I don't know in the areas you work, but certainly in the area I work, fall socks are often not removed to check feet. And this has been recently a source of damage where we've not been able to notice damage timeously. And use a barrier and manage the source of moisture effectively. Position to maximise perfusion. This means significant repositioning. All too often we see people being nursed for unreasonably long periods in the same position. When I review care rounding of patients who have developed pressure damage, I often see the care rounding has been carried out at the correct time intervals, but I see too often the lack of significant repositioning to reperfuse, and see patients in the sitting position because they don't sit perfectly placed. They sit with their heels out and their legs crossed over. So they are sitting in a position where their heels are at risk or lying on their back for continued unreasonably long periods of time. So let me make you think out of the box. Imagine you are watering a beautifully lush, healthy vegetable patch and somebody stands on your hose. This means there's no water getting to these vegetables, and all the vegetables wither and die. And that's exactly what's happening when we don't maximise reperfusion. And it's cell death, as Jacqui alluded to earlier. And that it means that the blood supply is not getting there to deliver the oxygen and nutrients and to remove all the toxic substances that have built up. So we cause cell death because we are not allowing the blood supply. Look, make sure you do actually check all areas and under any equipment I've already said. All equipment that can be safely removed, some equipment cannot, but pulse oximeter, on the toe, fall socks, foot protection, anti-embolic stockings, or even the patient's own socks, all need to be removed at every skin inspection. Equipment. We have so much equipment available to help us redistribute pressure and at times offload pressure. There is a difference which my colleague Duncan will allude to in the next talk. Use it. Don't have it in a cupboard. Know where it is, know how to use it, and use it at every opportunity. Don't let it gather dust. As simple as your electric reprofiling bed. You just need to bend the knee and you've already got offloading of the heels. We have cushions, we have boots, we have turn assist platforms, we have mattresses, but you do need to know how to use it correctly, how to assess for suitability, the fit and care of a patient with the equipment. Patients may not be concordant with any of that equipment, and you may actually have to revert back to something as basic as a pillow, but that needs to be a person-centred plan of care. But please do not leave the heels at risk. Skin health maintenance. We need clean and well moisturised skin to keep it healthy. So I would encourage the use of emollients. Individuals with frail or vulnerable skin are at increased risk of sustaining a wound. Just like people with skin conditions or comorbidities, their capacity to heal may be impaired. This creates a vicious circle of compromised skin integrity and non-healing. Individuals with compromised skin integrity are also at increased risk of wounds such as skin tears, pressure ulcers, and moisture-associated skin damage. Accountability. I think our NMC and healthcare support worker codes of conduct sum up beautifully our responsibilities. These are our professional bodies. And I'm just going to read some of our codes of conduct sections. Treat people as individuals and uphold their dignity. Treat people with kindness, respect and compassion. Make sure you deliver the fundamentals of care effectively. So that's skin inspection. Avoid making assumptions and recognise diversity and individual choice. That's your person-centred care. Make sure that any treatment, assistance or care for which you are responsible is delivered without undue delay. Timely interventions. Listen to people and respond to their preferences and concerns. Again, person-centred care. Make sure that people's physical, social and psychological needs are assessed and responded to. Act in the best interests of people at all times and always practice in line with the best available evidence. Family. Family members do want to help. If any of you have been on the other side where you are caring for a relative in hospital, you desperately want to be useful. You desperately want to help, not only by sharing information about that person, what matters to them. You want to feel useful in that person's journey. Involve them in any way you can to help deliver person-centred care, repositioning, anything. Engage with them, listen to them to develop meaningful person-centred care plans of care. Ensure they have the information to make informed choices. Don't assume that they know what they're doing. The paediatric teams do this very well. And just my final slide is it's everyone's responsibility. Everyone's responsible for keeping our patients safe. You, me, our allied health professionals, carers, everyone is responsible. Thank you. I am now going to hand over to my podiatry colleague, Duncan Stang, who I've known for such a long time. I can't even remember how long we go back, Duncan. So I'm going to hand over to you now.
Years, Heather. Thank you very much, Heather, and also Jacqui. Thank you very much indeed. This evening, I'm going to be talking to you about CPR for feet. And this is a campaign that I launched in Scotland as part of my Scottish Government role. So what is CPR for feet? It is a very simple system to make sure that all individuals entering any care setting have their feet checked and their feet checked for risk factors. And if we identify them being at risk, the appropriate protection must be put in place so we protect those individuals. And if we discover that they have an existing problem when we are checking them, we make sure that they are referred appropriately. This all came about when I was thinking about when people entered a care setting, what are the steps that had to be put in place? And that was we had to check them. We had to protect them if they were at risk, and we had to refer them, hence CPR. So why do we need CPR for feet? Medically acquired pressure damage, known as iatrogenic harm, is first of all unnecessary. It is easily preventable. It uses extra valuable resources to treat once pressure damage has occurred. It causes unnecessary distress to individuals within our care, and it costs the National Health Service vast sums of money. And part of that cost is due to the increasing risk of litigation. So the national campaign in Scotland, it is endorsed by the Scottish Government, and the CPR for feet has been officially endorsed by the Scottish Government Patient Safety Campaign, and the programme has been embedded into the Diabetes in Scotland policy, ensuring widespread adoption. This programme started off for individuals with diabetes, but has been now expanded to all individuals who are at risk. And the CPR for feet is now recognised as a key prevention strategy across all Scottish healthcare settings. And this you'll see here is the very simple poster that goes along with the CPR for feet campaign, showing the check, the protect, and the refer. This can be adapted for anybody who wishes to use this campaign in absolutely any way they wish. We basically set out to reduce iatrogenic harm because in 2013 we carried out an audit of over 1,000 patients with diabetes in hospital, and we realised that 2.4% of those individuals were developing iatrogenic harm while in our care. We carried out that audit again in 2023, and we had reduced that iatrogenic harm from 2.4% to 1.3%. So CPR for feet, as I said, set out to reduce iatrogenic harm in Scotland, and it reduced it from 2.4% to 1.3%. So we have nearly half the incidence of iatrogenic harm, and that is fantastic news. But there is still further work to do because any instance of pressure damage, especially where I was concentrating on the heels, should be avoided. And we really need to try and eradicate this problem and introduce simple strategies to do this. And to my mind, it is all about raising awareness, consistently educating our ever-changing care staff, and making sure that avoidance of pressure damage is forefront to their minds. So the cost impact of introducing CPR for feet In 2013, with the 2.4% of admissions for individuals with diabetes and the cost of £7,800 to treat an ulcer in these individuals, it was costing the NHS in Scotland 18.72 million. We reduced the heel ulcers to 1.3%, so we still had a cost of £10.14 million to treat those ulcers. And even taking into account of any extra pressure redistribution or relief devices that we were using, we managed to show an annual saving of £8.18 million. Now, Scotland has a small population. You think about introducing that on a larger scale across the UK, and just think of the financial impact that we could make on the saving to the National Health Service. So why do I feel that CPR for feet has been such a success in Scotland? The three-step approach is easy to remember and implement in busy clinical settings. Everybody is extremely busy these days. And it addresses real-life, long-existing problem with straightforward, simple solutions. And the effectiveness has been demonstrated with the results in the reduction of the preventable harm across Scotland. Data, sometimes we look at as clinicians, we think, oh, we've got to collect this, we've got to collect this data. But data drives improvement. Make sure we encourage the use of DATEX or a similar system to document pressure damage. This isn't as a finger-pointing mechanism and highlighting failure. It is really to embrace a learning culture and focus on learning and improving rather than a blame when incidents occur. And a prevention focus. Let's prevent this damage occurring and develop a proactive culture focused on preventing pressure damage. And use this to drive continuous improvement. Use this data to track progress and identify opportunities where we can improve care. So we introduced the product specifications, and there were two areas that we wanted to introduce: devices that were wearable for the patient to offload the heel, that were wipeable and reusable if that's what was required, and on support surfaces. Pillows come with their own risks, and knee brakes has limited effectiveness because quite often it's not used properly. So we felt we needed to redistribute pressure and reduce pressure on the heels and reduce pressure from the foot of the bed. In Scotland, we had a clinical advisory panel which was made up of infection control nurses, tissue viability nurses, ward staff, and podiatrists. This was a legal process, and that looked at all the products that were available, and we looked at what was the most appropriate to support the CPR campaign. And this national contract was made to tailor-made and has resulted in lower costs of the device. It ensured that we had the top quality product, and that it was evidence-based and clinically effective. And the commitment from TaylorMade to support each health board around the country with training was part of the award of the contract. And this contract, because of the cost savings it has made in both the devices and in the reduction of health service, as you've seen, is saving the National Health Service an absolute fortune. And it is a fabulous example of collaborative working. So very quickly, what we introduced was the heel safe pad. This is shown on top of the top sheet here, but is actually on it goes underneath the top sheet, so the patient doesn't even know it's there. This is to reduce the pressure on those heel areas. and it is especially effective when you have a patient who is getting in and out of bed independently, where wearing a device could cause a falls risk. This doesn't alleviate pressure, but it reduces pressure and is a very effective device and can be used in association with the SoleSafe. I don't know about you, but many occasions I've noticed when I've visited patients in hospital that their feet are pressed right against the end of the bed, causing pressure, and this is a fabulous device to prevent that. And in the occasion when you need to relieve, not just reduce the pressure on the heel, we introduce the foot-safe boot, which alleviates and raises the heel off the mattress, so completely alleviates the pressure. And this is worn for individuals who generally are non-ambulant or who have active foot, an active heel pressure damage or ulcer. If we look at the individuals on support surfaces, i.e. dynamic or alternating mattresses, they can reduce areas of pressure and they can be extremely effective, but they do not offload pressure. I don't think if you're caring for an individual on one of these surfaces that they are no longer at risk. They are very effective, but they only reduce pressure. They don't eradicate pressure. And you may need to relieve the pressure, not just reduce the pressure in certain circumstances. You would not need to put a heel safe on one of these surfaces. You may need a sole safe, but you also may need a foot safe to absolutely raise that heel and keep all pressure off it if that individual has current damage or is at very high risk. But no single solution is effective for everyone. We need solutions for every scenario. And although I have outlined a strategy that we've used, we still need to think about introducing individual care in certain circumstances. All the CPR for feet information is available on the Diabetes in Scotland website. It has product information, it has educational videos, presentations and support materials, and CPR for feet mirrored badges, ordering information, and these badges have been extremely successful. Anyone is able to access all of these resources on the website and use them in any way they wish. And even in an area of Scotland have adapted all of these. And if you look at the check, protect, refer, they've got a microscope, they've got a shield, and they've got an individual there. And it is just a slightly different take. You'll see the CPR for feet badges and also magnetic badges, which are relieve the heel that can be placed above the patient's bed. And these are ward packs, which can be very, very successful and can be adapted in any way. So consider introducing CPR for feet or something similar. We have to prevent avoidable harm. We have to prevent litigation. We must reduce treatment costs and also improve the quality of individuals within our care. And the key is keep it simple and keep our patients safe. And really do what we should have been doing all along. Thank you very much. I can now pass you back to Simon Dickerson from TaylorMade.
Thanks, Duncan. Thank you to our speakers. Apologies for the technical issues we had with Linda. We practiced everything before we ran through things today, and we had no issues with mics, so sound was a little up and down. So if any of you have any questions, please post them in the Q&A section and we'll direct those to our speakers this evening. We do have some pre-submitted questions I'm going to start from first. So this is an interesting one. Jacqui, this is coming your way because I think it's the question that probably gets asked the most. What is the best way to offload an at-risk heel?
Is to do an assessment of the patient and work out what works for them. You can have the best device in the world, it can do the most successful offloading, but if the patient finds it uncomfortable or has different wishes, then that device will not successfully offload the heel. If the patient's desire is to get up and out of the bed and you put them in a boot that reduces their ability to do that, they will either take it off or they will try and get out of the bed with it on and increase their risk of falls. So we can't say there's any one device. It is really about understanding what you're trying to achieve and what that patient's specific needs are in the environment that they're in, and remembering that in preventing one harm, you don't want to be causing a different harm. You don't want the patient falling just because you were trying to protect their heel.
Duncan, anything to add there?
We have to remember that there is a difference between reducing pressure to the heel and completely offloading the heel. And there are two different strategies. So it's pressure reduction and pressure offloading. Now, pressure offloading when you are lying recumbent on a bed can be very different from a different device that you might need to use, which can allow you to ambulate. And we used a device which had a metal area on the back if a patient was going to ambulate, which was called a Prafo device from memory. But it is all about doing the assessment. If the patient has to walk, then it has to be a device that you can walk in, or if they are in bed, it is a device that does raise that heel, but they can't ambulate in that.
Lindsay, anything to add?
No, I agree. As Polly mentioned, it's very much patient-centered. Got to risk assess everything that.
Yeah, so risk is everything. Your mic is still up and down, I'm afraid.
Can you hear me now? I'm going to squeeze forward.
Oh yeah, it's a little bit. We can hear you now. It was just dropping in and out a little.
Very much risk assessing your patient, and we would do that all along. In the Glasgow team, we have to risk assess, have to keep our patient safe. I know I sort of talked on a bit about false socks, but making sure they're on the right patient, checking underneath them. If the patient's at risk of falling, we would not always advocate wearing an offloading boot in bed because they may well get up and fall with that on. We also, at times, will utilise pillows and just really keeping it simple and safe. You're offloading with pillows, with the equipment that's available to you. And as we said, much as Jacqui said, patient-centred care, risk assessing, and doing what works for the patient. Because if they're non-compliant with what we're
So expanding on that then, another question we actually had submitted after the last webinar, advice for healthcare professionals from the panel on people who work in an area or a ward or a unit where they may only have access to one type of device. And as you said, Jacqui, not every device is suitable for everybody for lots of reasons. What advice would you give to that healthcare professional who perhaps doesn't have as much choice or variety that they think they may need? Jacqui, do you want to?
Jacqui, sorry, that's fine.
Jacqui, do you want to have a go at that?
Yeah, I think it's a really difficult thing, isn't it? It's about looking at what else is available to you, being creative with your resources. So it depends on what the device is that you've got in the first place. And most of us do have pillows, and as both Duncan and Lindsay have alluded to, you can always use pillows. It depends on the quality of your pillows, because sometimes if you use a pillow, you finish up with the legs supported on just the fabric and the pillow stuffing either side. And you can use things like changing the position of the bed, articulating the bed so that you're slightly lifting the patient's legs upwards, which helps. It doesn't completely offload the leg, but it helps relieve the pressure a little bit from the heel. And think about the positions you're putting the patient in. So if you are trying to remove the pressure from the heel, can the patient tolerate side lying? That will completely take the pressure off the heel, but you're putting the pressure in a different place. So it is about being creative, and it is about thinking, do you need to make a case for having something more available? But it's kind of a double-edged sword. The more options you've got, the more complicated it gets. But the fewer options you've got, the more questions you get when you get patients who don't fit within that 85 to 90% of patients who that device is probably suitable for.
I think it's very much evidence in something. You have to be seen to be something and not ignoring that your patient is at risk. And if you, as you're saying, one piece of equipment in your ward, there are other things that you can adapt to support your patient. but we can't be seen to be nothing and ignoring the fact that our patient is at risk.
Lindsay, your microphone's terrible, I'm
Can you
afraid.
hear me? I'm so sorry.
It sounds like a 1990s Kentucky Fried Chicken drive-through, if anyone can remember how bad that used to be. So just moving on slightly to a question that we've got, which is, I'll start with Duncan on this one. So Chelsea Keelty from Doncaster has asked, is CPR for feet only introduced in Scotland currently? And she's put, this would be a very simple and effective thing to take forward to many ward areas. So, Duncan, do you want to talk about your experience outside of Scotland with CPR? And then, Jacqui, maybe you can give us an angle on how you see this may working, because my understanding of the healthcare system is Scotland's very integrated and health boards work together and there was a national role, but perhaps England's not quite that. So maybe we can cover that off in our answers, Duncan and Jacqui. Is that okay?
Yeah, absolutely. I've been contacted by many people saying, I've just seen, or they've maybe seen me presenting at a conference and this, and I'll get bombarded by people saying, you know, this is so simple. And as I said during my presentation, anyone can use any of the resources to this and adapt it in any way. Just last week, there was a trust down in England who asked me if they could use it but adapt it. And I emailed straight back and say, use anything you want. It is the ethos around CPR for feet that is the important thing. And having the support materials with it are very helpful, but it is the simple ethos. I've got 46 years of experience of working within the NHS, and trying to introduce something like CPR, even in somewhere like Scotland that works very closely together, is still difficult to get system change, but it is easier when it is something simple. Get CPR or something similar, make sure it's included in your current paperwork. Don't have a whole load of separate paperwork just for CPR. Get it involved in your current paperwork and keep it simple. And remember, if it's not documented, it never happened. So make sure that you show you've checked, and if they are at risk, that they have been protected. But anyone can use any of the resources by either emailing me or going straight onto the Diabetes in Scotland website and downloading any of those materials free of charge.
So, Jacqui, how might this work for England then, rather than with your vast experience and hat on here? We've got lots of trusts, lots of healthcare providers working in different ways, perhaps even wards working differently on one corridor to another. Where do you think CPR might fit? Is that a good fit for England and the NHS, do you think?
I think we're trying to give a consistent message across the whole of England that our preventative bundle is the SSKIN bundle. But within that, I think a lot of it maps what Duncan is talking about. So his check is our S for skin, which is skin assessment and skin care, which covers the check and protect. The referral is part of the G for giving. I really don't mind how people help to implement things.
Yeah.
As long as they are doing something that works in their situation. So a lot of the way that implementation fails is that it's not adapted to local environment. It doesn't work for that particular team or that particular patient group. And as long as they are doing those really fundamental elements of the bundle, and CPR is part of the bundle, it just happens to be different letters. I know lots of people who have different acronyms. So some have got Move It, some have got Heal Lift, some have asking with an E instead of asking with a G. If it works for your organisation, and if they are ticking those fundamental things of making sure there is risk assessment, of making sure there is skin checking examination, if they are making sure skin care is delivered, and that the rest of the things about the patient are also being managed, I really don't mind how you do that. If you want to implement playing a song every 2 hours that tells the patient to stand up, which is what they do in the States on some of their wards, they have a little klaxon goes off and the patients stand themselves up. If it works in your organisation, if it gets your staff to do it, then I'm all for it. And it's what works locally that makes a difference. And if they buy into it, then do it. Does that help?
Yeah, I think that the clear message from all of you is we just need to be more and make sure we've got the right tools on board to deal with the various presentations we've got. We have a question that appeared in the chat around heel relieving AFO. So I know the individual who asked that question, and I'm going to merge it with another question we got, and that is, what guidance do we need to consider, and what safety features do we need to consider when we're dealing with a patient with an active heel ulcer who wants to stand and walk? What strategies have we got for bed? How many hours a day do people need to be wearing something with an active ulcer in terms of offloading? And how do we make sure those people, if they do move, are safe?
Simon, can you explain AFO? Because I just had to Google
AFO.
it.
So an AFO is an ankle foot orthosis. So an orthosis is a splint, and an AFO goes from the back of your knee to the tip of your toe. So the one that is part of CPR is called a pressure relieving AFO or a PRAFO. So that is an orthotic strategy, but I don't want to answer the questions. I'm going to give it to Duncan. There you go, Duncan. All yours, because you'll see a lot of these with the diabetes caseload.
There are various devices out there. Ranging from, some of them have a plastic area, a very rigid plastic area to relieve the pressure from the heel, and some have a metal one. And these have a sole plate on them as well. Some are padded and some are not so padded, but it allows the individual to walk. But when I say allow the individual to walk, allows the individual to mobilize. You can't go out and walk 10 miles in one of these devices. This device is so that the individual can basically move around their house, etc., etc. You don't want them doing a lot of walking in these devices. You can also have a heel, a rear foot pressure relieving shoe where you basically walk on the forefoot and your heel is suspended, but yet again you're moving the pressure to the forefoot, so you have to be very careful and be checking that area, or the individual has to be checking that area very, very carefully, that you're not just moving the pressure somewhere else and causing another problem. So yes, these AFOs are very good, both for individuals lying in bed and for doing limited ambulation, but not walking for miles in them, and the same for a heel relief shoe, which I say all devices have will move pressure to somewhere else, so you have to be very, very careful of those other areas, especially for a heel relieving shoe, not so much for an AFO.
So Lindsay, taking that on then, if we're thinking about ward strategies for patients with heel ulcers, what should somebody do in that setting if they're a healthcare assistant or a nurse or a member of the care team or even a family member, and the patient is not getting on with the device, they're not tolerant of it? One of the questions in the chat was, could you use a device like that in bed instead of using an inflatable or a cushioned or a padded either offloader or redistribution device? What advice would you give to patients in order to try to make sure that they're getting optimal care if they're not getting on with something?
Okay, so in our first instance, we would record somewhere and the patient be better now. Hearing me all right?
It's a bit up and down still.
Are you hearing me any better now? If I look
Yes.
forward? Okay, I'll just dive in the screen. We would be recording that the patient was not tolerating the equipment that we had originally put. In the second instance, we would ask our nursing staff to repair the patient's orthotics again and record that, because we would be looking for an alternative. I know we mentioned pillows anyway, but pillows tend to be a last resort. Utilizing the pillows to offload until we can an alternative. Of patients at times are quite frequently not tolerating the equipment that we have to be recording what we've done and looking for the advice of our clinical experts in that field, which would be the orthotics team. But again, not doing anything.
Yeah.
we can't not be doing nothing.
So if we run into complications, basically we're back to the R of CPR, which is refer on to another service. And in some parts of the country, just so everyone knows, I'm an orthotist by profession. Orthotics departments are sometimes called patient appliances, and they're also called surgical appliances.
Yep.
If you struggle to get in touch with orthotics departments, because believe it or not, some hospitals don't have them, but there should be access to podiatry services. So orthotics would be your first point of call if you have orthotists on site. If they're not available, then obviously the tissue viability team are really important in this process, but the podiatrists may all be able to help you, because there are some custom offloading strategies your podiatrist from the high risk team can also deliver. So thank you, Duncan, and thank you, Jacqui and Heather, for your fantastic insights and knowledge and advice to us all. Just so everyone is aware, you can submit questions through the Q&A section on the top toolbar of Teams. We have got some pre-submitted questions we'll also be working through. Someone just has put something in the questions already. Will the presentations and resources be sent out? The answer is yes. We will be releasing the webinar after the next webinar session, which is planned for the 8th of April. And would hugely appreciate anyone recommending this going forwards to their colleagues. We will be emailing out a link to you all. So if I can get all speakers back on camera for me with mics off, we'll take some pre-submitted questions which have been sent to us by different people. So first one, I'm going to pass to Heather. Heather, we've had a question interesting to know what you might do differently in terms of prevention and treatment of pressure sores for somebody with a spinal cord injury.
You have to be very, very careful with people with spinal cord injury, because you cannot put any equipment in there that will compromise the spinal cord. The foot protection is paramount, and as far as I'm aware, Duncan, you may be able to help me here, there is no specific device that's contraindicated for foot protection in spinal cord, but every spinal cord injury unit has their own spinal cord protocols, and you have to follow them to the letter. So if the person who has asked the question, do they work in a spinal injury unit or not? But if they do not work in a spinal injury unit, any spinal injury unit in the country will be only too happy to share their protocols, which they follow religiously.
Right,
Heather,
thanks, Heather.
Heather, you commented that I might be able to have some input in this. We have to remember, if somebody has a spinal injury, they have probably lost any feeling or the perception of pain anyway, like a neuropathy in somebody with diabetes. So I think you'll agree that the checks on these individuals, as they will not be able to tell you when they've maybe got some pain or discomfort, that is vitally important in these individuals.
Yeah, and I think it depends on whether you're talking about in that acute phase, doesn't it, where you're trying to minimise any further harm, or you're talking about a person living with spinal cord injury. And most patients with SCI have got very robust care plans, treatment plans for how they manage at home and what should happen to them if they require admission to hospital. And the one thing I would say about them is if they have a treatment plan that works for them, then try and follow it, because they've tried it, they've tested, they know that it works for them in their normal circumstances. And I think sometimes we are very guilty if we bring somebody into hospital and we give them what we think works, whereas people who have chronic long-term conditions, Heather talked a lot about individualised plans of care. She talked about listening to families. Spinal injured patients are a really good example of where that is absolutely crucial. Listen to what they usually do. Listen to what they tell you works for them.
Fabulous. So more questions to get through. Jacqui, you've just answered the end of that one, but I've got one I'm going to direct your way straight away. So a question for somebody who has had a heel pressure ulcer, but this is now healed. What would you do in terms of change of prescription for treating that person if they were still an inpatient and in bed?
I think if the pressure ulcer's healed, it would depend on the cause. So if they developed a pressure ulcer because of some acute thing, you know, they had a massive stroke or they were being resuscitated or they were trapped in a vehicle, and the cause of that pressure ulcer has gone away. And if you heal that, great. The skin remains much more fragile. If you're talking about a patient who is complex, multimorbid, frail, perhaps elderly, even if you heal that pressure ulcer, those risk factors remain the same. So I would continue with the same level of prevention that I had previously. I would take into consideration what's helped healing. So have they healed because they have got better, they've got more mobile? So Duncan mentioned in his presentation, you know, we really need to think about, does the device limit people's independence? So if they got the pressure ulcer because they were very unwell, they required a lot of assistance, and as they've got better and more mobile, then you might change the device, but the level of risk remains high because they've got skin that is now not as it was. The skin structures are not the same. It will remain fragile for a considerable length of time, and you have to consider the other risk factors.
Anything to add, Heather, Duncan, or Heather's? I can see Heather's chomping at the bit there.
Yeah, it's just to remember that we don't downgrade pressure damage. If it's been a grade 3 pressure damage, it's always a grade 3, but it's a healing or a healed grade 3. And just to go back to person-centered goals. So it may be that that person is moving through a rehabilitation phase, and we may need to compromise on patient care if you want to get that person up and mobile. But as Jacqui says, these risks remain the same, although the wound may appear healed, remains vulnerable. So it's getting that person-centered care plan to meet the person-centered goals and getting that balance right, that we want to rehabilitate people, but at the same time we do really need to maintain their skin integrity.
I would just add, from my point of view, if somebody has had a previous pressure damage to their heel, I would steer away from pressure reduction, and I would want to be relieving the pressure on that area. Pressure reduction on skin which is previously broken down might not be sufficient to stop it breaking down again, but pressure relief would be. So I would up the strategy for that individual.
Splendid. So a question has just appeared in chat from Fran McNabb. So let's go straight to this one. And I'm going to ask all three of you around this. So I'm going to split this up, Fran, if you don't mind, into two separate parts. So Fran's asking a question about fall socks and their contribution to harming heels when patients are repositioned in bed. My first question is, do we have any evidence that this could happen? And if we don't have the evidence, what caution could we take if people are wearing fall socks to try to mitigate this risk? Heather, do you want to go first?
Yeah, this has recently raised its head in Scotland-wide, not just Greater Glasgow and Clyde, because there's no real evidence. I've just printed off the literature search to read on the train tomorrow. I'm heading to Bradford. There's no real evidence that these socks do actually prevent falls. And there actually is an infection control risk associated with them. So there's some very good guidance out there about when they should be worn and when they should not be worn. So certainly in Greater Glasgow and Clyde, we have formed a short life working group comprising of infection control, falls and myself, because it's not the fall socks themselves that cause the pressure damage, it is the lack of removing them to look at feet. So patients really should have their own footwear put on as soon as possible to remove the requirement for false socks, and they should only be worn in bed if it's patients that are risk takers when they're in bed, and so watch this space for more guidance coming out, up-to-date guidance coming out from Glasgow, but we are taking the national because it's a national interest. So that's that one.
Anything to add, Jacqui?
Yeah, I would agree, Heather. We see occasional reports of patients developing pressure damage from these socks, because you can see the pattern, the pattern of the silicone on the bottom, but it's unusual. Most of the damage we think is because of lack of inspection, because people don't remove the socks and they can get caught up in the bedding and all sorts of things. And particularly if they've got anti-embolic stockings on and then anti-fall socks, skin does not get inspected, and skin inspection is absolutely crucial. That's where we pick up the early warning signs, that really early skin damage, and that's our biggest point of being able to reverse any potential harm.
Splendid. So another question, I'll direct this one to yourself, Duncan, if that's okay. We had a question submitted during the registration about patients who may get up in the night and they cannot take off an offloading device if it's applied to them. So there is obviously a clear risk they might try to walk in them, and that's not safe. The suggestion is that they currently use pillows to try to reduce heel pressure, and ask if there's an alternative and what are the potential risks of pillows versus other strategies.
Well, what we introduced in Scotland was the heel safe device, and we put one of those on every bed in the vascular ward and a lot of elderly care wards. These don't relieve pressure, but they reduce pressure. So if you've got somebody that is getting in and out of bed independently, and if you, they might be suffering from dementia or any of these things, so you cannot attach a device to them because it will cause a falls risk. But you have to understand that you're only reducing pressure, and in some cases that might not be sufficient, but you have to weigh that up against the risk of somebody falling and creating damage elsewhere with that. So we introduced the heel safe pad, which has been extremely successful, and the concordance for it is virtually 100%, because most individuals don't even know it's on the bed. But it only reduces pressure, doesn't relieve, but for most instances it will take away the falls risk, but we have to make sure that we are checking those individuals, because if they are developing any damage because we're only reducing the pressure, then we would need a different strategy. Use of pillows, used appropriately on somebody who doesn't move around a bed, can be very, very successful, but most people move around a bed in some shape or form, and even though that you have positioned them beautifully, 10 minutes later or a few minutes later that can have changed. So if somebody can't move at all, then it can be very successful, but I would say a heel safe is for most of these instances is a very successful strategy that has worked for us in Scotland.
If I could just add to that, if the patient is mobile enough to get in and out of bed by themselves, it is likely, not entirely 100%, that they can move their legs, so they will move them in the bed. You've got a falls risk potentially even with pillows, because if they're moving their legs about, if they are dragging their legs to get out of the bed, the chance of them kicking the pillow out of the bed as they do that and tripping over the pillow is almost as bad as them tripping over the whatever foot protection you've put on. So something that's under the sheet is probably much safer for people. There's less for them to get tangled in, to trip over, or whatever might cause them to fall.
Okay, so that kind of leads on to another question, which I'm going to pass Heather's way, which is, what would be the best devices for pressure relief over sort of ankles, prominent ankle bones, malleoli, as well as the heel, Heather?
I don't think
I've had a bit of experience with that, Heather, if you want me to jump on that one. We recently introduced one of the other tailor-made products, a Heel Pro Advanced, which is a very cushioned device, and it was absolutely fabulous at cushioning the malleolus area. It is a single patient use device because of the makeup of the device, but we have introduced that, and it's on, I think it's on FP10 and is prescribable out in the community, and that has proved extremely successful.
Yeah, there's lots of devices out there, and you know, I wouldn't want to, you know, be prescribing a particular device, depending, again, it's all down to, you know, being person-centered. But just to mirror what Duncan said, I've just completed a 100-patient evaluation using the Heal Pro Advance, where out of the 100 patients in very vulnerable adults, we've had 0 pressure damage using these devices. So that, and you know, very comfortable and very, you know, enclosed round, and yeah, but that's one of many devices, but that's certainly proved valuable in Glasgow's portfolio of devices we can offer.
So another question just been posted by Laura Hughes, and she asks, with working with within the community and elderly population, would you recommend using pillows in between the legs to prevent knees from pressing together, mainly for patients who aren't mobile? Jacqui, do you have any advice on this type of patient?
I think the thing with pillows is it depends on the quality of the pillow and the material in the pillows. So if you're in their own home, you've got their pillows. If they're feather pillows, if they've got loose fill, the content all moves to the end if you compress it. So what you finish up with is just layers of fabric between the knees. There are lots of other devices you can use more safely. If you have a really good quality foam pillow and you can guarantee it will stay in place, if the patient is quite immobile, then yes, absolutely. But the other thing you need to think about is the size of the pillow, because it can be quite uncomfortable to lie with a pillow between your legs. And if somebody is thin and frail, you can be causing pain on the hips by lifting the knee quite a distance. So it's a very individualized assessment. And I would really want to think about the size and shape of the patient, what else they're doing, how bony their knees are, how they lie, how you can best position them. Are there other things you can use? Could you use some of the inflatable or other kind of wedges that might sit more comfortably between their knees and they can't compress as easily? As Heather said with the previous question, it's really difficult to give an answer to a question without knowing the individual patient's circumstances, and safety has to be paramount, and you really need to think about what works best for that individual.
And there are different products out on the market that's specifically designed for that instead of pillows. So you know, patient positioners and things. So there are different products that may be a bit safer than a pillow. As Jacqui said, it all depends on the quality of your pillow and how dense it is, and it may be very uncomfortable because a lot of these people are very frail and thin and may not tolerate something as thick as a pillow.
Fantastic, thank you. Another question I'll pass to Jacqui this time. What are the common mistakes when using SSKIN bundles, and how can they be avoided?
Sorry, coughing fit. Common mistakes when using a SSKIN bundle: not following the bundle, or only doing part of the bundle, or doing the bundle cursorily, or doing the assessment and not the treatment plan. I think, you know, the important thing is that it's not a tick box exercise. You're not taking a form to say, I've done the SSKIN bundle, and not doing anything to the patient. The whole idea is it should trigger action, and that it should be individualized. So you shouldn't be doing a 2-hourly skin inspection for everybody in your care, because some people need an hourly one and some people need a 4-hourly one or 4-hourly repositioning. So the biggest flaws when people implement bundles is to say that for people who look like this, do this, because patients don't look uniform. The things that make them at risk differ. So one patient may be immobile but sensate, and another may be insensate but mobile, and the things you do should be different. So the challenge is getting people to see the bundles as a personalised tool, not a blanket thing that we tick to say we've delivered the same care for everybody. For me, that's the biggest flaw in the bundles of any sort. So whether it's, Duncan's CPR, which is a bundle, it's a bundle of activities, the SSKIN bundle, the SSKIN bundle, whatever that is, they need to be interpreted for that individual that you are delivering care for.
Thank you very much.
Can I just add
Claire,
something to that?
Sorry, Duncan. Go ahead.
Sorry. We have to remember, though, no matter what we do, if it's not documented, it didn't happen. So we have to make sure we document. And I always say, if you're going to introduce something like CPR for feet, integrate it into whatever skin bundle or whatever care plan you're doing, just very, very simply, because we found in our audit that the evidence that CPR for feet that had actually been carried out was very, very low, even though there was evidence, you could see visual evidence if a device had been fitted, etc., but it wasn't noted in the notes. So we have to make sure it is put in the notes, or we are leaving ourselves wide open to litigation. If it's not written down, it didn't happen.
So just a final question, which is an amalgamation of a few pre-submitted questions and some more that have been posted this evening, which is for all of you really as a closing question. What advice would you give to a healthcare professional who felt it was difficult to get access to equipment, or perhaps they only had access to one device in the community or in a hospital or on a ward or in a care setting? What advice would you give to that person to ensure that they've got the tools they need to address the variations in patient presentations that they likely to see? Jacqui, do you want to have a go first at that? Oh, Duncan's
No,
off.
it's okay.
Duncan,
Heather can go first.
Jacqui, on you go.
Jacqui, go ahead.
I think it's always difficult, isn't it? Because we are resource constrained. And when you work in a specialist service, you have to make decisions based on evidence. So what you have available in your area should be based on the available evidence that we have, and not that may in some instances not meet a very specific individual's needs. So it is about, if you have got one of those patients who don't conform to what the evidence says, if they're outside what the guidelines do, because some patients are very, very complex, you may be in a challenging environment or challenging circumstances, you have to be really clear when making your case why you need something different. And that's not a case of, I think this will work better. You have to absolutely pull out what it is specifically that the product you're asking for does that is different to the products that you have available. So you have to have a really clear picture of what the patient need is and what the piece of equipment will contribute to that.
Thanks, Jacqui. Heather, do you have anything to add?
My mantra is cost-effective care without compromise. Know the evidence behind any product, and really look at what's available there on the market, so that you're not wasting resources, but at the same time you're giving the person the best available there is, without compromising care.
And Duncan, finally to close.
Well, as I say, we standardised in Scotland the pressure redistribution and the pressure relief devices that were being used through our national contract. And I encouraged the hospital wards to have these on top up so that they didn't run out of these devices. Just a stock of these devices, and ones that some were single patient use, but mostly could be reusable as well, to ensure the cost effectiveness of that. And what the national contract did was make sure that we had devices that were fit for purpose and effective.
Thank you very much indeed. So firstly, thank you to everybody who has joined us this evening, and special thanks have to go to our amazing three presenters for sharing their insights, skill and passion. We do have another session planned in April, and we'll be sending out the link. If we could share that with colleagues, that would be hugely appreciated. We will also be sending out an email with all of the answers to all of the questions from our guest speakers from the 2 events following the second event. So there will be a Q&A sheet that comes out, as well as the opportunity to give us some feedback at TaylorMade on education, as we hope to try to do lots of innovative things in the future. And anyone filling that in will enter a prize draw for £50 Marks and Spencer's voucher. So finally, thank you all again. Have a wonderful evening, and thank you for giving up your precious time. Hopefully this can help us all avoid patients getting injured when we can prevent it. Many thanks. Have a great evening.
Good evening.